So thank you so much again for joining us. Our speaker is, again, we are very pleased to have Dr. Andrew Moore, who has been presenting this for many years. He's a pulmonary and critical care medicine fellow at Stanford. He grew up in Virginia and completed his bachelor in neuroscience at the College of William and Mary, and he followed it by his MD at University of Virginia School of Medicine, and then his residency and chief residency here at Stanford. As a fellow here, his research focuses on the use of bioinformatics to develop better diagnostic and prognostic tools in the ICU. So thank you so much, Dr. Moore. Please take it over. We are very grateful to have you.
Oh, well, thank you for saying that. And yeah, no, this has been something I've done for a little while now, and it's near and dear to my heart. So I'm glad to hear that the desire to learn this is there. So I'll go ahead and start just by sharing a Google link to the medical terminology sort of quick guide. This is going to be used sort of through the interactive portions of this talk, which I'll go through in just a little bit. And then I will go ahead and share my screen. And I'll apologize for the stark background I have going on right now. I don't know why there's no color in the walls at the biomedical informatics building or biomedical innovations building, but yeah, it is a stark building for sure. So let me go ahead and get sort of Zoom all set up for myself so I can see everyone that's chatting. And we'll go ahead and get started. So yeah, so hi everybody. I'm Andrew, and I've been doing this for a little while now. It's a topic that's very near and dear to my heart. And it's sort of focused on sort of a rapid intro to medical terminology, which I think is really important. And I'll give a quick caveat, which is to say, like, certainly we can't go over sort of all the nitty-gritty details of medical terminology. And so the idea here is mainly to give you all some tools that you can use as you run into medical terminology in your day-to-day work lives and even your home lives. So before we begin, I just want to preface by saying I have no relevant disclosures or financial interests. And these are our objectives for today. So we're going to interpret key roots, prefixes, and suffixes for medical terms. We're going to apply important anatomic terminology. We're going to recognize the importance of acronyms in medical practice. We're going to understand when to use medical acronyms and when they should be avoided. We're going to apply common medical acronyms, abbreviations, and colloquialisms. And we'll identify and use resources to help improve health literacy. And so as far as nuts and bolts, we'll start off with a little bit of a lecture as to why terminology is difficult and methods we can use to simplify it a bit. And then for most of the course, we'll actually be practicing with some of the common and not so common terms and phrases. And so for much of the interactive portion of the lecture, we'll be using the medical terminology cheat sheet, which I've included as an attachment. So let us know if you can't access it, and we'll send it another way. So I liken medical terminology to a whole different country. And I think country is very important because it's not just language that's the barrier. There's a huge cultural component to it beyond just language. So most of the people in the healthcare field are crazy busy. So most of us speak way too fast. We use a ton of shorthand to try to maximize efficiency. And even once you get past the shorthand, the terms that the shorthand stands for make no sense. So then you go to the dictionary, you look up the term, but then all it does is refer to a disease that you have no idea what the whole process, the whole disease is. And then the whole process just sort of starts all over again. And then beyond the language barrier, there are these strange customs that are there depending on sort of what field of medicine you're in. Even for me, I use very different language talking to a surgeon versus a medicine doc, to my co-fellows versus my attendings. So yeah, you'll see strange customs sort of throughout the medical field. And then beyond that, hospitals themselves are just incredibly confusing. Often they've had these like little sort of build-ons throughout the years and very different floors and ups and downs. And construction going on is going on in 300p right now. And so all this really adds up to being just wholly overwhelming. And again, the goal of today isn't to fix all of those issues, but to give you a bit of an idea of the basics that can be used to decode what we're trying to say. So let's start with the language part of this foreign culture. So this seems super basic, but I think it's easy to forget about this. And I know this is probably causing flashbacks to grade school, but don't worry, I'm not going to go all Latin 101 on you. But I do think it's important to note that medical terms are very formulaic. And if you break them down into their components, it's usually fairly straightforward to determine their meaning. So this is bringing us back to grade school, but remember that most words have a root, a prefix, and a suffix. So a root is the central topic of the word, usually the disease, procedure, or body part that you're acting on. The prefix is a modifier before the root. Usually it tries to give more information about location, time, or quantity. And then finally, the suffix, which comes after the root, and usually gives information as far as sort of what's actually happening. So when you put all this together, you can demystify most medical lingo. All right, so prefixes are the beginning of words. So this seems like a very good place to start. So remember, prefixes usually try to give additional information about the topic, often providing anatomic or quantitative information. So like Dr. Seuss is just describing how many or what type of fish we're discussing. So let's start with quantitative prefixes. So a lot of these are fairly intuitive since we use them in real life, right? So here's uni, which means one. So for example, a unicycle is just one wheel. To continue this analogy, bi or diplo is two. So a bicycle has two wheels. Tri is three, tricycle. Less commonly used, less commonly seen. I don't know if I've ever seen one of these in real life. Actually, no, that's not true. You see those like little beer cycles around the cities. But yeah, so I guess technically you could call those a tetracycle, which is four wheels. And then these are a little bit less intuitive. So oligo refers to a few things. And we often use this to describe the distribution of a disease. So for instance, oligoarthritis describes inflammation involving just a few joints, usually talking about two to four joints. And when you say that to a medicine doctor, that gives a very different differential than, say, a monoarthritis, so a single joint arthritis, versus like polyarthritis, which is describing many joints. So poly means many, so here's many bicycles. And actually, I would argue that this is probably too many bicycles, which would then be the prefix hyper. And then it can also give an idea of sort of size. So a microcycle would be a bike that's too small. Another way you could potentially say this is hypo, which is just too little. And then macro, which is too large. So next up, we have prefixes that denote sort of location or time. So the first that I bring up is AB and AD. So this is most often used in neuromuscular testing. So abduction is away from center, whereas adduction is toward the center. So describing this accurately plays a really important role in localizing neuromuscular and joint pathologies. Amba means both sides. So in sort of general terminology, this is often used to describe sort of ambidextrous people, which can use both hands sort of equally, as you're seeing here. Things that denote sort of time or location. So ante or pre is before or in front of, and then post is behind or after. And then ecto and endo are antonyms. So ecto and exo means outside of, and endo means inside of. So for this example here, the endometrium is the lining of the uterus. And so sort of normal pregnancy should implant on sort of the endometrium. And then an ectopic pregnancy is a pregnancy that lies outside of the uterus, most often in the fallopian tube, and can be a medical emergency. And it's something that we very much are concerned with abdominal pain in sort of young and middle-aged women. So these are other particularly important location prefixes which help us to denote the severity of disease based on their anatomic correlates. So on the right are what are called abdominal aortic aneurysms. So you can see that sort of the normal vessel caliber should be about this big. And then you see this sort of bulging. So that suggests what's called an aneurysm, where it's too large. When you're speaking to sort of doctors about sort of the aneurysm, or when they're speaking amongst each other, the most important thing is where they're located relative to the renal arteries. So right here are your renal arteries. So these are two arteries that go to your kidneys. And obviously kidney perfusion is incredibly, incredibly important. And so where they are relative to the renal arteries determines how high risk they are and how they are repaired. So for example, a suprarenal AAA starts above the renal arteries and travels down. A pararenal is basically right there. The juxtarenal is near it, but not quite involving it. And then an infrarenal is below the renal artery. So this infrarenal is much easier to repair and is the safest and lowest risk, whereas these suprarenal AAAs are very, very difficult to repair and require a lot more sort of planning before a procedure takes place. And then finally, there are qualitative prefixes. So these help us to figure out what the topic is doing. Is it good, bad, etc.? So anti is against. So for instance, an antibody is something that binds to proteins in the body. So these are antigens that are in the body, and the antibody is binding to it. Auto refers to self. So for instance, autoimmune disease is when antibodies inappropriately target our own antigens. So examples of autoimmune diseases are things like lupus, rheumatoid arthritis, and a number of others. U is normal. So for instance, euthyroid is when your thyroid levels are normal, compared to hyperthyroidism, which is when your thyroid levels are too high, or hypothyroidism, when your thyroid levels are too low. Dys is abnormal. So for instance, dysreflexia is when you have abnormal reflexes. And then mal is kind of a continuation of dys with even sort of worse connotations. So mal is a bad or abnormal response. Morph is shape. So often when you hear something like a morphologic diagnosis, that's actually a pathologic term where someone is just looking at the organs and saying they're sort of abnormal or abnormally shaped, or any number of other things that can come from just sort of looking at the shape of that organ or that pathology. Pseudo is considered false. So going back to our sort of aneurysm example, a true aneurysm is when all of the walls of the blood vessel expand. So there are 3 layers to any blood vessel. And if all 3 expand, that's called a true aneurysm. Sometimes blood can break through 2 of the layers and then just get walled off by a single layer of the blood vessel. And so when you have parts of those wall left over and then it's just a single wall that's containing this sort of aneurysm, that's called a pseudoaneurysm. And actually it's much higher risk of rupture and has to be acted on differently because it has that thinner wall. And so it's a higher risk of rupture and is more of an emergency. So this is just kind of an overview of prefixes and sort of how they sort of relate to the root. All right, so that's it for prefixes. So let's move on now to suffixes. So I think of suffixes as the sauce, and not just because they start with the same letter and sound kind of similar, but they really are what carries most words. Usually the topic itself is kind of bland. Like I wouldn't want pasta by itself. But suffixes are there to tell you what's actually going on in a given word. So these are quite important. So let's use myo as the root. So myo refers to a muscle, and suffixes are really going to spice it up a bit. So for example, myalgia, the suffix here is denoting a state. So myalgia is muscular pain, which can be normal if you have a good workout, or it can be abnormal if you have a muscular disease and haven't worked out and your muscles are painful, sort of separate from that. Myositis is abnormal inflammation of the muscle. So it can present with abnormal myalgias or muscle pain or muscle weakness. So this is actually your body sort of attacking the muscle, or can actually be an infection in the muscle causing myositis. So this is inflammation in the muscle. A myoma is a muscular tumor. So oma means tumor. And often we'll add on a prefix to it as well. So what we're looking at here are leiomyomas, which are smooth muscle tumors in the uterus. Colloquially, it would be called fibroids. Next, we'll talk about procedural suffixes. So these are things that are actually being done to the root. So a myectomy is a procedure in which we actually resect the muscle. So this is in particular showing a septomyectomy. So this is the septum of the heart. So this is your left ventricle and the outflow to the aorta. So this is your aortic valve right here. And you can see that this is a condition called hypertrophic cardiomyopathy, where there's abnormal growth of the muscle in the heart. And that blocks the blood flow from the left ventricle to the aorta. And so what we'll do is we'll actually go in and we'll resect that septum, or we'll do an ablation procedure of that septum to reduce that muscle mass and allow for a better outflow tract into the aorta. So that's a myectomy. A myotomy is when we cut into the muscle. So instead of cutting the muscle out, we just cut into the muscle. So one example where this is used is for a condition called achalasia. So this is abnormal sort of muscle tone in the esophagus that prevents food from passing into the stomach correctly. So we cut into the muscle at the top of the stomach. This loosens the opening and then allows food to pass appropriately. And that's called a myotomy. Suffixes can also denote actions. So we're going to use sort of heme as an example here, which is a root that means blood. So one example here is hemolysis. So lysis is breakdown. So hemolysis is breakdown of blood cells. So one of the things we look for in hemolysis is something called schistocytes. So schistocytes are these sort of helmet-shaped blood cells that show that these blood cells have been broken down. And depending on the context, this can be a sign of really severe inflammation or even sort of a medical emergency, depending on the situation. Hematology, as you know, is the study of blood. Hemophagocytosis. So this is a big word, but breaking it apart, you can see blood, phago, which is eating, and then cytosis, which is cells. So this is when blood cells actually eat other cells. So a good example of that are macrophages, which are these special types of cells that come in and eat other cells. And so this can be normal. This is an appropriate reaction to cells that are sort of past their use and need to be eaten up and recycled. And in some cases, it can be quite severe and can lead to a condition called HLH, or hemophagocytic lymphohistiocytosis, which is really severe response to usually cancer or infections that actually requires basically anti-cancer therapies to calm the macrophages down. Hematopoiesis is the production of blood. So this usually happens in the bone marrow. And so this is the starting out with a stem cell and then producing all the different components of the blood. One thing I do want to point out is that sometimes there's no root at all. So just a prefix and a suffix. So I don't want you to let that fool you. The same general rules still apply here. So using a as an example, remember that a means lack of, and phasia is a suffix that means speech. So aphasia is a condition when someone is unable to speak, most frequently caused by strokes in a certain part of the brain. Another good example of this is atrophy. So this is lack of growth. And most often you'll hear this in reference to muscles. That suggests that muscles have decreased in size and aren't strong enough to support the needed functions. But it can also be used in many other situations, such as atrophy of skills, or any number of other situations. Apnea is lack of breathing. So probably the most common context for this is sleep apnea, which is when breathing pauses during sleep. And the treatment for that is a machine here that sort of opens up the connection between the mouth and the lungs to allow air to pass. And that's a CPAP machine. And so here we just have a breakdown of the major types of suffixes used. So in general, they can be procedural, denote actions, or they can denote states. And then there are also many others that aren't fully captured here, but I think this is a good start to get us rolling. And so finally, we get to roots, which is where we're really going to put it all together. So for roots, I split them into general roots, which are true for a lot of different medical specialties, and then more specialized roots. Now, since we've already gone through all the prefixes and suffixes, this is where I'm going to ask you all to put all the pieces together. So for this next set, I'm going to give you all a word, and then you'll have a minute to decipher it, and then send it our way in the chat. And then we'll go over it together. And again, just like with anything, this is a safe space. So loud and wrong is much appreciated. I think we learn best from putting a foot forward and then learning from any mistakes we might make. Once again, I'm going to go ahead and put the medical terminology sheet in the chat, and then we'll go ahead and get started with some of these words. All right, so starting off with meningitis. So again, about a minute to go through and sort out what you think this is, and place it in the chat. Great. So yeah, we have some rolling in here, and this is perfect. Yeah. So this is so meninges is your root, and then itis is inflammation. So meningitis is inflammation of the meninges. Now you all are probably saying, what in the world is a meninges? And reasonable question. So meninges are the lining of the brain. So you kind of have two different major inflammations in the brain. So you have meningitis and you have encephalitis. So meningitis is the lining of the brain. Encephalitis is actually the brain itself is being inflamed. So this lining of the brain is where a lot of sort of the lymph and blood vessels travel. And so often is sort of the first spot where you get an infection of the brain. And so there are two major ones to talk about. So bacterial meningitis, fairly straightforward. It's a bacterial infection of this lining. And then aseptic meningitis, which you can likely work through, right? A is none, septic is culture or infection. And so aseptic meningitis is inflammation without growth on cultures. This used to be mainly viral meningitis because we had a difficult time testing for viruses. But now that we've gotten much better at testing for viruses, most aseptic meningitis is actually caused by autoimmune conditions or inflammatory reactions to medications. So really, really nice job there. So next up is polyarthritis. Yeah, perfect. So I'm seeing a lot of people putting into the chat, and I think all of y'all are exactly right. So poly is many, arth is joint, itis is inflammation. So putting that all together, that's inflammation of many joints. usually talking about greater than 4. So this is a quite nice picture of already 4 joints that are inflamed, and you can imagine that there are many other joints that are inflamed. And as we talked about, polyarthritis versus oligoarthritis versus monoarthritis gives a very different differential. And so classic polyarthritis is generally talking about osteoarthritis, which is a condition in which joints wear down over time. It's actually sort of bone on bone causing inflammation rather than the immune system causing inflammation. Perfect. So next up is myocarditis. Yeah, so everyone nailed it here. So this is inflammation of the heart muscle. So myo is muscle, card is heart, itis is inflammation. So all told, that's inflammation of the muscles of the heart. There are many types of carditis, right? So you can have a pericarditis, you can have myocarditis. And that does actually give you a different differential when it's in the muscle versus in the region surrounding the muscle. So this is most commonly seen in the setting of viral infections. There's a particular virus that tends to cause this. It can also be seen in autoimmune conditions and in response to certain anti-cancer therapies. And then other places where it's gotten a lot of press is concerns that it could be caused by vaccines, though this is certainly significantly overblown, but probably somewhere you've seen it in the press. What about otalgia? Yeah, so you all nailed it. So ot is ear, algia is pain. So this is sort of the classic thing seen with swimmer's ear or ear infections, middle ear infections as well. So you'll see a child sort of tugging on their ear, and that's suggestive of an ear infection. It's that pain in the ear that sort of cues you into it. And the medical term for that would be otalgia. So sort of continuing that, what is hyperalgesia? Yeah, I love it. So I have sort of too much pain or too much something, right? And that's exactly right. So hyper is too much, and then algia is pain. And so hyperalgesia is increased sensitivity to pain. So this is an inappropriately extreme response to pain, out of proportion of what we can find physiologically, right? So probably the best example of this is seen in fibromyalgia, where people have really extreme sensitivity to pain and touch, often particularly on their shoulders and back, without a real clear physiologic correlate in the muscles or bones or anything like that. Like we can't find a spinal cord impingement or muscle inflammation or anything like that. And this really gets into sort of the mind-body axis, which is something that we just haven't cracked yet, where there's definitely a feedback loop where sensitivity to pain primes your mind and body to be even more sensitive, and we just haven't figured out how to effectively break that loop in certain people. So that's a really good example of this sort of increased sensitivity to pain, which we would term hyperalgesia. What about anencephaly? Yeah, I'm getting a lot of question marks for this one, and I think that's exactly right. Like, what what could this be? Like, how is there a medical condition where you don't have a brain? But that's exactly what it is. So an is absence, cephalon is head. So it's an absence of the portion of the skull and brain in particular. So this is a developmental condition. We generally detect it fairly early in pregnancy because it's something that happens very early on in development, and it's not compatible with life. And so this is something that you all have likely seen in the news, particularly in the context of sort of overturning Roe v. Wade. Um, so this is one of the conditions that has been sort of prevalent in the news. So what about apraxia? Yeah, you all nailed it. So A is absence, so missing something, and then prax is movement. So apraxia is this inability to perform certain movements or inability to sort of initiate certain movements. So two common contexts where you'll see this is with strokes and Parkinson's. And one of the more common difficulties you see is in buttoning shirts. So our occupational therapists who sort of focus on being able to sort of do the sort of small motor movements that are necessary to sort of function day to day. This is one of the common things they'll sort of assess in being able to sort of function at home. So apraxia is sort of the inability to do these certain movements. What about exophthalmos? Yeah, this is perfect. So X is out, ophthalmo is eyes. It's a little bit of a stretch, but once you sort of put those together, it's the eyes sort of moving out of where they're supposed to be in anatomic space. And so it's bulging of the eyes. So it's most commonly seen in Graves' disease, which is a thyroid disorder. And it's actually because the autoantibody that affects the fat, the autoantibody that causes Graves' disease can affect the fat and muscle around the eye. And it's very important to recognize because it actually does affect how we treat the disease. So patients with Graves' disease require different treatments depending on whether they have exophthalmos or not. So sort of continuing that, so what is ophthalmoplegia? Yeah, so you all nailed it. So continuing from that last one, so ophthalmo is eye. The P's always get confusing, but plegia in this case is paralysis. And so it's a condition where the eye is paralyzed. And so this is a good example of a patient trying to look right, and this right eye is paralyzed, and then trying to look left, and this left eye is paralyzed. And so this is actually a very special form of ophthalmoplegia called internuclear ophthalmoplegia, which localized to a very specialized tract in the brain, and is most commonly a sign of multiple sclerosis, which is a condition where your body attacks the nerves. So this is ophthalmoplegia, which is paralysis of the eyes, and the direction really helps tell us exactly where the paralysis is coming from. What about dysphagia? Yeah, perfect. So I'm glad some people fell into my trap, which is, again, the P's just they tend to be quite confusing. Um, but there's a big difference between a G and an S, which we'll actually get into in a little bit. But so dis is abnormal. Phasia with an S is speech. And so this is difficulty expressing or comprehending speech and language. So again, this is commonly seen in the setting of strokes to a certain part of the left brain that causes difficulty either producing words or understanding words. And then exactly what type of it is, we'll actually sort of add more things in front of it to help us figure out what type of dysphagia it is. What about muscular dystrophy? Yeah, you all nailed it. So dys is abnormal, trophy is growth. So this is abnormal growth of muscles. And the most common place you'll see this is probably the most common condition where this is true is Duchenne muscular dystrophy, which is a genetic condition. And what's interesting is often what you'll see very early on in sort of growth is you actually see quite large calves. And the reason the calves are so large is because the muscle is actually getting infiltrated with fat. So it really is abnormal growth of these muscles that causes this. So yeah, that's muscular dystrophy. What about oropharyngeal dysphagia? Nailed it. Yeah. So this is a this is a big one, but it really does give you a lot of sort of details about what's going on. So oro is mouth, pharynx is pharynx, which is sort of the back part of the mouth. Dys is abnormal. Phasia is eating. So I mentioned that this was going to come back. So this is difficulty eating or swallowing due to dysfunction of the mouth and throat. Um, so there's sort of key places where you can have difficulty swallowing or eating. So one is can be in the chewing and swallowing part. Others can be it gets stuck in the esophagus. And so those are obviously very different sort of pathologies. And so where the person is having the difficulty eating is sort of how we target our workup and interventions. What about retropharyngeal abscess? Perfect. Yeah. So, yes. Sorry, I didn't give you all abscess on the thing. So that's exactly right. So retro is behind, pharynx is pharynx, which is sort of the throat. And so this is an abscess, which is a type of infection in the space behind the pharynx. So remember, this is your pharynx, and then there's this space behind it called the retropharyngeal space. So these are medical emergencies for two reasons. One is if the abscess grows enough, you can see how easily it would close off the space that's needed for you to breathe and to swallow. So stuff can get stuck up here and you just can't breathe. The other is that you can see this sort of fascial lining in the space travels down the spine. And so you can have these infections spread either to the spine or even worse, down into the heart, which as you can imagine is really not great. And so that's part of the reason why we sort of differentiate the location of the abscess as retropharyngeal versus pharyngeal. And so it can be really helpful to sort of qualify those locations. What about adenocarcinoma? Yeah, well, nailed it. So adeno is gland, carcin is tumor or cancer, oma is tumor. So you can have tumors that aren't cancers, right? So carcinoma is when you're talking about a tumor related to cancer. And then adeno is where it's coming from, which is glandular tissue. So this is by far the most common type of cancer. And you can imagine why, right? So glands are these cells that are constantly working and being replaced. So with so much turnover, that creates a really high risk of genetic issues with these sort of cells turning over that lead to cancers. And then sort of beyond that, there are many different types of adenocarcinoma, depending on the glandular tissue it's coming from. So the most common types of cancers that you all probably hear of in day-to-day is like a lung adenocarcinoma, a prostate adenocarcinoma, breast adenocarcinoma, and GI adenocarcinomas. And so we can sort of qualify its location beyond the type of tumor once we know what type it is. What about an acoustic neuroma? Yeah, y'all nailed it. So aku is ear, Ner is nerve, oma is tumor. And I particularly brought this up after the adenocarcinoma because this isn't a cancer tumor. This is a tumor that just arises from the space around this nerve, and it impinges on the nerve going to the ear. And so the most common thing that you see with this is actually balance issues, although you can get hearing issues with it as well. So this is a relatively common benign tumor that you can see. All right, what about choledocholithiasis? This is a big one. Yeah, so this was a lot of stuff all combined into one, right? So chole is bile, doco is duct, lith is stones, iasis is a condition. So this is a condition in which you have stones in the bile duct. So the bile duct is the thing that connects the gallbladder up to the liver and then takes the output from the liver and the gallbladder into the intestines. And what those things do is they're sort of enzymes that help to absorb fat in the intestines. And so because the gallbladder is constantly secreting this stuff, sometimes it turns into stones, and those stones can get stuck in the duct. And so choledocholithiasis is just when you have stones. When you have inflammation related to it, that's cholecystitis, that's gallbladder inflammation, which is most often caused by stones. What about enteroscopy? Yeah, so this is a tough one. So probably the place where you have seen this is more colonoscopy, right? Or esophagogastroduodenoscopy, which we call for short EGD. But the non-specific one is enteroscopy. And actually, this is sort of a combination of uh, of suffixes, which both sort of denote a procedure as well as what we're doing. So in particular, this is actually we insert a scope into the intestines and take a look inside. And so the two most common places where you see this in the intestines is most commonly a colonoscopy. And then the other place you'll sometimes see it is a esophagogastroduodenoscopy, where we go through the mouth and look in the esophagus and stomach. What about lithotripsy? Love it. Yeah. So this is when you break up stones. And so this is any procedure that breaks apart stones. The most common one is probably extracorporeal shockwave lithotripsy. So this is when we use shockwaves outside the body to break up kidney stones. So this is kidney, bladder, and then there's a stone in the middle. And so these shockwaves go in and break it up and allow you to pee it out. There are other types of lithotripsy, like we can actually use lasers to do the lithotripsy from the inside. So there are a number of different ways we can do it, but probably the most common is this shockwave lithotripsy. And so this is used mainly for kidney stones. What about laparotomy? Yeah, so this is another one of the procedures. So laparo is abdomen, tomy is incision. So it's an abdominal surgery with an open incision, as opposed to a laparoscopy where we basically insert a camera through a very small port. So when you hear the word exploratory laparotomy, usually what that means is we've done this large incision to look take a closer look at the abdomen with sort of direct visualization, as opposed again to laparoscopy where we actually look with the camera. What about a tracheostomy? Yeah, you all nailed it. So tracheo is the trachea. So that's that part right here. And then a stomy is an opening. So it's a hole in the neck through the trachea, which is generally used to place a breathing tube, although you can just have a hole without a breathing tube in place and people can just breathe through it. So that's what you're seeing right here, which is a breathing tube that goes into the trachea and sort of bypasses the mouth. So the reason that we do this is, one is talking is very important to people and being able to use their mouths is very important to people. So if someone needs to be on a breathing machine for a very, very long time because of respiratory failure, often we'll place the breathing tube in their neck to allow them to speak and to allow them to eat food and things like that. The other reason we'll do it is some people have head and neck cancers or something like that, where actually the connection here doesn't work. And so we actually have to bypass it to allow them to breathe. So that's a tracheostomy. And so I see a side question in the note, which is what's a mastectomy? So mast is breast and then ectomy is removal. And so a mastectomy is just total removal of the whole breast. And so that is contrasted with what's called a lumpectomy. So you have mastectomy and you have lumpectomy. So lumpectomy is when you remove just the area around the cancer or tumor. So lumpectomy is just the tumor, mastectomy is the whole breast. As far as ectomy versus ostomy, so ectomy is when you actually remove some piece of it. Ostomy is when you create an opening. So for instance, with this tracheostomy, what we actually do is we just cut a hole in here. We don't remove anything. We just cut a hole and then we can place things into it. Whereas an ectomy, like a tracheectomy, would be when we actually cut out a piece of the trachea, which is something we'll occasionally do if people have either a cancer in their trachea or have other issues in their trachea that require us to put them back together. So ectomy is a removal of a piece of that organ, whereas ostomy is just creating a hole into that organ. Nice, great questions, y'all. So this was a nice, actually, as lead in. So what is a thoracoscopic pneumonectomy? So putting all this stuff together. Love it. Yeah, this was a this was a big one. Oh, I love it. Yeah, a little alley-oop there. So yeah, so that's exactly right. So thoraco is thorax, scope is observed, pneumo is lung, ectomy is removal. So this is a thoracic camera-guided removal of the lung. And so what we actually do is we go in with these ports and we actually cut out the entire lung in this case. If you do just a piece of the lung, that's called a lobectomy. The other place where you'll actually see this colloquially named is called a VATS, which is a video-assisted thoracoscopic surgery. So VATS pneumonectomy or VATS lobectomy is just another way of saying this exact same thing. Nice, great job, y'all. So we actually nailed it on timing. So we've gotten through the language basics. So next up, we'll talk a little bit about anatomy. I recognize I've been talking for a very long time, so why don't we take, just 3-4 minutes, let you all get a break, and then we can sort of restart at 10:05 to get through sort of the rest of this. And any questions in the meantime, shoot me any questions and we can answer those while people take whatever break they might have.
Fantastic. This has been really amazing. Thank you so much. This is so educational and something that will stay with us, really. Thank you so much. And to the audience, please, I see a lot of you participating, but I see a lot of you not. So try to participate because this is how you will also learn better and it will stay with you longer. So please, participation is great. So enjoy your mini break and we'll see you back.
Up as people. So the deafening silence of Zoom never. It's been 3 years and I'm still not quite used to it, but I do really appreciate everyone's participation. It's been really amazing, and again, I think helpful both for me to sort of understand where I can improve this year to year, and then hopefully helpful for you all as you sort of think through these problems. As a quick reminder for anyone who sort of joined us after I sent this out, or it's lost in the feed, here again is the worksheet or the guide, which we'll be using sort of later on in this lecture as well. So just for your use later. Perfect. So we've gotten through a lot of the language basics. So now let's talk a little bit about anatomy. So to define anatomy, first we really have to understand anatomic position and our planes. So let's start with anatomic position. So the anatomic position is just like this man here, which is standing up, facing forward, palms facing forward. And the palms facing forward is quite important. So all anatomic terms are relative to this positioning. So anterior or ventral is towards the front. So you can see right here. Posterior or dorsal is towards the back. So remember, dorsal fins are on the back of dolphins. Superior or cranial is toward the head. Inferior or caudal is towards the feet. Lateral is towards the side. Medial is towards the middle. And then proximal is towards the origin. And then distal is further from the origin. So proximal is more like the shoulder, distal is further out at the fingertips. And where this really comes into play is when we discuss imaging. So that's by far the most frequent place this is going to come up. So this is a CT scan, which is where we use radiation to slice up the body and create projections based on tissue density. And CT scans are where these planes play a really important role. So there are three basic tissue planes. So transverse, this is also called axial, as in computed axial tomography, is cutting a person just like this into inferior and superior portions. And so you're kind of looking from either the head or the feet at the middle of the person. So this is an axial plane right here. The coronal plane cuts the person in the middle from front to back and divides a person into lateral and medial portions. So whenever I hear coronal, I think sun. So coronal is the sun sort of shining around you. So that's the coronal planes. So you can sort of see it right here, cutting this way. So this is an example of what a coronal plane looks like. You can see the person's left side and their right side, and then we're sort of looking from left to right. And then the sagittal plane is cutting a person from front to back. So it divides a person into lateral and medial portions. Divides a person into anterior and posterior portions is the easiest way to say it. So this is a good example of a sagittal plane right here, where you can see the person's front and the person's back. You see the spine right here, so this is the person's back. So this is a good example of what a sagittal plane looks like. So as if you're cutting from the front to the back. And then the last thing that I'll add is that by convention, radiologists reverse right and left. Don't ask me why they do this. I think it's only to cause medical errors, to be honest with you. But right is your left side is your right side is your left side. So that's just something that you get used to the more you see images. But at first it's a little bit disorienting. This is the front, so anterior or ventral. And then this is the back, or posterior or dorsal in an axial plane. Next up is sagittal. So again, remember this is cutting from front to back. So this is the front, the anterior or ventral portion. This is the back, so the posterior dorsal portion, as you can see by the spine right here. You have superior or cranial up at the top. And then you have inferior or caudal at the bottom. And then this is coronal imaging, which is cutting a person from left to right. So remember the sun. So again, left is right, right is left. So this is the right side. This is the left side. This is the top, the superior cranial side. And then this is inferior or caudal. So this is actually a person's lungs. You can see the trachea coming down and branching out into their lungs. And then down here, you can see their diaphragms. And then this is their liver on the right side and their spleen on the left side. So there's a ton of anatomy to learn, but ultimately most of it comes down to three important anatomic cavities, which is where the majority of pathology and surgeries fall. So these are the cranial cavity or the vertebral cavities. So these are sort of where most of your spinal fluid is and where the spinal cord lives. So that's this right here. There's the thoracic cavity. So this is where your heart and your lungs live. And then there's the abdominopelvic cavity, which is where the abdominal organs live. And it's again separated from the thoracic cavity by the diaphragm. So probably 90% of CTs are going to be either head CTs, chest CTs, thoracic CTs, or abdominal pelvic CTs. And that's because these are sort of the three major areas where pathology tends to happen in the acute setting. So real quick knowledge check here. Feel free to add into the chart. So is the abdomen or the thorax more caudal? Yeah, it's a tough one. Caudal is one of my least favorite words. So remember that caudal also means inferior, which means towards the feet. I mix it up all the time. I actually mixed it up as I was looking through this lecture. I realized I said it wrong, so don't feel bad. But yeah, so the abdomen is more caudal because it's closer to the feet or inferior. Are the palms dorsal or ventral? Nice, yeah. So in your anatomic position, your palms are ventral, facing forward, whereas the back of your hand is dorsal. And it's hard to think about the palms facing forward, but just remember that the back of the hand is the back of the hand, and so the back faces the back. Which joint is more distal, 1 or 2? Nice, yeah. So distal means further from the origin. And so in this case, joint 1 is more distal than joint 2. And actually it's called that. So this is called the proximal interphalangeal joint, and this is the distal interphalangeal joint, or the DIP and PIP. And so most of our anatomic names are also based on sort of these anatomic positions. All right, what anatomic plane are we looking at right now? Yeah, so this is the transverse or axial plane. So again, looking at you as if you're cutting sort of through the body and looking from the top or the bottom. Then this is just a lung mass right here. So what side of the body is the lung mass on? Nice, can't fool y'all. So yeah, this is the right side. So remember that radiologists made it so that left is right, right is left. So this is the right side of the body. And then is the mass lateral or medial to the heart? Perfect. Yeah, so this is lateral to the heart. So lateral means that you're further from the midline. So this is going to be lateral to the heart. Nice. You guys are ready to be radiologists. So next one, what anatomic plane are we in now? Yeah, perfect. So this is the sagittal plane. So again, cutting from front to back. So what we're looking at here, this is actually, remember, spine. This is your chest wall. This is your heart and lungs. This is your esophagus coming down. What we see right here is a little food bolus that's stuck in the esophagus. So where is the food bolus relative to the spine? Yeah, so this is really tough, right? Because remember that when you're looking at sagittal images, we don't necessarily know what's happening sort of further from the midline or not. All we can tell is anterior and posterior. So this would be anterior or ventral to the spine. What about the food bolus relative to the heart? So remember, heart is right here. Nice. Yeah. So again, what we can tell here is whether something is anterior, posterior, or superior, inferior. And so in this case, the food bolus, this is a little bit of a stretch, posterior or dorsal, and then more importantly, superior or cranial to the heart. So how is this used in real life? So anatomy is super tough and complicated, but honestly, I think anatomy has done a really good job of making names for anatomic things fairly sort of straightforward once you sort of know your anatomic positions. So it provides for these sort of common naming conventions. So a good example here, so this is the bottom of the brain, and this is all the blood vessels that are going up to the brain. And then you can see that all of this stuff goes exactly how you would expect, right? So the anterior cerebral artery is at the front of the brain, and travels up and hits the cerebrum. Then you have middle, and then you have your posterior cerebral arteries. All of these are sort of based on what part of the cerebrum they're acting on. Then you have your superior cerebellar artery, which provides blood flow to the cerebellum. And then depending on positions, you have also anterior, inferior, and then posterior, inferior cerebellar arteries. And so all of these, as you sort of understand your anatomic positions and what they're feeding, make perfect sense. It also provides really important diagnostic information. So in the cerebral cavity, strokes are a really good example. So strokes are when blood flow to an area of the brain gets stopped, or actually when you have a brain bleed can also be a stroke. But in most common cases, it's blood flow gets stopped due to a clot. And so the middle cerebrum, which is fed by the middle cerebral artery, is involved in language and movement. So what you'll often see with a middle cerebral stroke is that weakness and difficulty with language. So things like aphasia, which we talked about earlier, which helps the neurologist localize the lesion and also determine how large the lesion is likely to be before they even get to the scanner. What about in the abdominal cavity? So this sort of positioning also gives us very important diagnostic information. So in the abdominal cavity, if you describe the position of a patient's pain, you can relatively quickly narrow your differential. So for instance, the liver and the gallbladder, so if a patient had choledocholithiasis or cholecystitis, like we talked about before, would have right upper quadrant pain. And so when someone comes in and they say they have abdominal pain, the very first thing we ask is, where is it? And then we can sort of localize where it most likely is. A sort of other example of that is right lower quadrant pain, which most often we think about as appendicitis, because that's where the appendix lives. And finally, in the thoracic cavity, we often describe pathology based on where it is relative to the heart. So a mass in front of the heart is where things like the thymus, the thyroid, and the parathyroid live. And so a mass in front of the heart, so anterior mediastinal mass, is most often going to be something like a thymoma or a thyroid tumor or a parathyroid mass. Whereas the middle mediastinum tends to be from either the lymph nodes of the heart or the bronchi that run through there, or it can actually be a cyst around the heart. And then the posterior mediastinum is where a lot of the nerves from the spine are coming out. And so you think about sort of nerve tumors in the back of and behind the heart in the thoracic cavity. And so this sort of positioning gives us a lot of information about what things are likely to be before we even go in and take a tissue sample. And then finally, using these anatomic terms can provide a lot of prognostic information. And so a heart attack is when an artery of the heart becomes clogged, and we often describe the lesions as proximal or distal. So which would you rather have if you had a heart attack? Would you prefer a proximal or a distal clot? Yeah, you all nailed it, right? So distal means that it's further from the origin of the blood vessel, which means that it's perfusing a lot less of the heart. So often if you have what's called either a proximal left main or a proximal LAD lesion, also known as the widowmaker, these lesions are really, really severe heart attacks, whereas a more distal occlusion tends to cause less functional impairment and is a less severe heart attack. And so that's sort of the use of these proximal versus distal in terms of giving prognostic information. So that's sort of the broad overview of anatomy. Next, I'm going to dive into medical acronyms and shorthand. And so first, I just want to talk about, why in the world do we use medical acronyms and shorthand? As we have developed these sort of electronic medical records, right? We could literally use a dot phrase that turns these acronyms into their full terms without us having to write even the letters needed for the acronym. So it's very easy to get rid of these acronyms, but they do provide a lot of useful information. So this is a good example of what we call a one-liner. So one-liners are these things that you say to try and get a sense of what's going on with a patient relatively quickly. And so you can see that this is a very, very dense one-liner, right? So this is a 65-year-old woman with a past medical history of hypertension and type 2 diabetes mellitus, presenting with a right-sided anterior inferior cerebellar artery cerebrovascular accident. Like, that's a mouthful. If you show that to me on a piece of paper, it would take me a long time to read it and to understand what's going on. And it's easy to misinformation. Just because if you misread even a single part of this, like the anterior inferior, that totally changes sort of your differential and what's going on. So it can be shortened relatively quickly to just this. And just looking at this, within a split second, I know exactly what's going on. And so this really is where acronyms come into play, is being able to pass on information very, very quickly. Again, amongst people who understand the same acronym. So it has to be a sort of common understanding. So next up, we're going to go through some of the common acronyms and some examples of how they're used. So first, we're going to look at acronyms for disease states. So this is by no means comprehensive, but it is a good example of conditions that we frequently use shorthand for. So these should, again, all be available on your handout. I would say things that you commonly see are sort of these CAD, COPD, CHF. So these are sort of your common comorbidities that people come in with exacerbations of. Your kidney injuries, like end-stage renal disease, which is kidney disease leading to the requirement of dialysis. And then two big ones we use quite frequently are HLD and HTN, which are hyperlipidemia or high cholesterol, and hypertension or high blood pressure. And then another big one to think about is sort of this differentiation between URI and UTI. So upper respiratory tract infection versus a urinary tract infection are things that I think commonly come up and you'll see quite frequently. So here's an example of how they're used. So 84-year-old PMH of CAD presenting with CHF exacerbation. So does anyone want to take a stab at this one? And then we'll keep building on this one as we move along as far as giving more information in a relative shorthand. Nice. Yeah, you all nailed it. So if we were to sort of spread this out, what it would be is an 84-year-old female with a past medical history of coronary artery disease presenting with congestive heart failure exacerbation. And so it sort of tells you the risk factor that this patient has, which is coronary artery disease, which caused the heart failure, which is causing this exacerbation. Now, importantly, I think you all probably saw me sort of struggle even to say the one-liner. And I think it is important to say that there's a difference in how you write and how you speak. So I would 100% write this as a one-liner. If I was talking to someone else about this patient using words, I wouldn't say CAD. I would say coronary artery disease, because that our brains kind of adapts to much more quickly, rather than trying to convert an acronym from speech into language. So the next place we frequently use acronyms is in the history taking part. So these are parts of the history or symptoms the patient has. And I would say the most confusing four are probably the C's. So you'll see them right here. So remember, CC is chief complaint. CB is complicated by. So this is when, for instance, hypertension is complicated by kidney disease or something like that. Concern for and consistent with are sort of two ends of the same spectrum, where you give a list of things that the patient is presenting with, and then you're giving sort of an idea of the differential. So if you're less sure of what the cause is, you might say concern for. If you're fairly sure of what the condition is, you'll say probably consistent with, or CW. So here's the next example. So sort of building on what we just did, does anyone want to sort of add on the next part? And yeah, I see some, as people are sort of thinking through this one, I see someone bring up CHB. And yeah, none of these are perfect, and you'll have to use them in context to some extent. I would say CHD often is congenital heart disease, and then CHF is usually congestive heart failure. So it may vary by location, what exactly speaks to what, but CHD is usually congenital heart disease, so things like tetralogy of Fallot or things like that, whereas CHF with the F is congestive heart failure. So I think probably the DOE and PND are getting people. And so this is a complicated one. Oh, nice. They're rolling in. So yeah, so this is sort of an idea of past medical history plus symptoms coming in. And so this is an 84-year-old female with a past medical history of coronary artery disease, presenting with dyspnea on exertion, which is shortness of breath with movement, and something called paroxysmal nocturnal dyspnea, which is where when someone lays down, they get more short of breath. That's most concerning for a congestive heart failure exacerbation. So these are fairly classic symptoms for a congestive heart failure exacerbation. And we'll have a chance to go through all of these in a lot of depth with for you all to try them on your own in just a little bit as well. So I hope you don't feel left out in getting through these. So next up is prescribing. So these are sort of common shorthand that's used in prescribing. So many of you probably know this PRN, which is short for pro rata, which just means as needed. IV is intravenous, IM is intramuscular. And then you can also say like how often someone is supposed to take something, which is before meals, every morning or every night, twice daily, 3 times daily, things like that. So sort of expanding on our example. So I'll let you guys soak this in for a little bit, and then we can go through sort of what this actually means. Yeah, so adding on to what we did before. So this is an 84-year-old female, same past medical history, same presentation, coming in with the heart failure exacerbation, for which we gave Lasix, which is a diuretic that helps relieve congestion. We gave it 20 milligrams through the veins with improvement. So the patient is feeling better after the medication that we gave via the intravenous route. I would say these are less commonly used, but we sometimes will use shorthand for medications. I would say common ones that you'll see. So APAP is short for acetaminophen, which is Tylenol. ASA is short for aspirin. CTX is short for ceftriaxone, which is an antibiotic. DAPT is dual antiplatelet therapy. This is a combination of blood thinners that's used after heart attacks. NSAIDs are non-steroidal anti-inflammatories. This is something that you'll certainly see quite a bit. So NSAIDs are things like ibuprofen or naproxen. And these are two sort of more specialized medications that are used to control pain or to treat stroke symptoms. So continuing this, so the big change here is that we've added on this on ASA. So this is now an 84-year-old female with a past medical history of coronary artery disease on aspirin at home, presenting with dyspnea on exertion and paroxysmal nocturnal dyspnea, concerning for congestive heart failure exacerbation. And then the other place where we'll frequently use this is in labs. So these are sort of common lab shorthands that you'll see. So CBC is your blood count. So this is telling you how many white blood cells you have, whether you're anemic or not, how high your red blood cells are, how good your platelets are. A diff is when we separate the white blood cells into the type of white blood cells they are. So are they neutrophils? Are they monocytes? Are they eosinophils? A BMP is your basic metabolic panel. So this is looking mainly at how well your kidneys are doing. A CMP is a comprehensive metabolic panel, which is all of the basic metabolic panel plus liver function tests. So this is looking at whether your liver is inflamed or whether there's a blockage in your liver. The shorthand for liver function tests is LFTs. So again, that's just looking for liver inflammation and blockages. And then coags are your coagulation studies. So these are studies that are looking to see how well your blood is coagulating or grouping together to stop bleeding. So continuing this, so same sort of root of this, but now this patient has a CMP that's notable for an AKI and elevated LFTs. So this is just providing a little bit more information on top of sort of the symptoms and showing us some lab abnormalities. Yeah, so I see AKI equals acute kidney injury, and that's exactly right. So what we're looking at here is 84-year-old female, past medical history of coronary artery disease, presenting with dyspnea on exertion and paroxysmal nocturnal dyspnea with a comprehensive metabolic panel, so that thing that looks at kidney function and liver function, showing that the patient has an acute kidney injury, suggesting that enough blood is not flowing to the kidneys. And then also elevated liver function tests, suggesting that because there's so much congestion, that blood is actually going backwards and affecting the liver, concerning for a congestive heart failure exacerbation. And then finally are the procedures. So I talked a little bit about these procedures already, or a couple of these procedures already. So a good example is VATS, which again is that video-assisted thoracoscopic surgery. So this is again where you go in with the camera and take a look at the lungs. I talked about the XLAP, which is that exploratory laparotomy, which is when you actually make the big incision in the abdomen as opposed to going in with the cameras. Another big one that you'll commonly see is CABG, which is a coronary artery bypass grafting. So that's a surgery to repair the heart vessels after heart attacks. And then there's a number of sort of others that you'll see quite frequently as well for reference. So just to continue to add to it, now this is an 84-year-old female with a PMH of CAD status post-CABG. So all this is saying now is that this 84-year-old female has coronary artery disease, and it was bad enough that she needed a coronary artery bypass graft. So just sort of gives you some risk stratification as far as how significant that coronary artery disease was. So how can I look these things up on my own? So certainly I mentioned at the beginning that the list that I gave you is definitely not comprehensive. It's more just to sort of dip your toes in and sort of get you thinking about these things. Yeah, Google. So Google is absolutely a great resource. I would say that separate from Google, to look for sort of more medical specific resources, Lane Library is just excellent. So the librarians there are amazing, and so they'll be able to help you with anything that you can't get on the web, or with the resources that they provide. And the two that I really do want to highlight here, so these are their resources, and the two that I really do want to highlight are UpToDate, and then also Dynamed. So both of these are excellent resources to sort of sort out sort of what these medical conditions are. So UpToDate is very disease-specific information about pathology, epidemiology, diagnosis, treatment, and guidelines. So it really is sort of a one-stop shop for medical management of most diseases. And then the nice thing about it is it also offers sort of patient-level information about diseases as well. And so it's a nice resource to go to get sort of an overview of the disease that is possible to give to patients even. And then Dynamed Plus is very similar to UpToDate, but it's written in a bit more of an abridged format. So it's really nice for sort of rapid information. It's like bullet points, very straightforward, very easy to get through. One that I really like for acronyms is onelook.com. This actually it's fairly good for medical acronyms too. So that's something I will use if I run into something that I'm not totally sure about. So this is a good place for it, and it's actually useful for day-to-day acronyms as well. And then for labs, so for instance, if you weren't sure what a CBC is or what a CMP is or things like that, Stanford Labs actually has a lab test guide where you can just type in that even the shorthand, and it'll tell you what the components of that test are. Another one that can be accessed through Lane Library are sort of prescription information. So the two that I really like are Lexicomp and Micromedex. And actually UpToDate has sort of engulfed a lot of this prescription information as well. So all of this has information about when to give these medications, how to give these medications, and what medications are actually available within the Stanford pharmacy. So this is the moment of truth. So here are 5 one-liners that I'd like for you all to decipher. So I'll give you 15 minutes to go through them. So we'll end this at, let me do the math here. So we'll do, let's say, 10:52-ish. And I want you to go through them, each one individually, and then type them out for yourself. And then we'll go through them in turn. And you can send them in the chat, and we'll talk through them. So go ahead and go through for yourself, getting through each of these. And then we'll go through them sort of one by one at around about 10:52-ish.
Thank you again. This is fantastic. Wonderful. So we'll be back in 10, like 12 minutes. Is that right?
Yeah, I think that's probably about right. Yeah, so hopefully you had some time to sort of think through these and parse these apart. And I don't expect that you all got through all of them, and that's very much okay. I think this is as much sort of a learning example as we go through them together. So I see some answers to the first one, and you all really did nail it. So this is a 26-year-old female. She has lupus that's severe enough that it caused end-stage renal disease, which is basically kidney disease that requires dialysis, severe joint inflammation, and then also steroid-induced diabetes, presenting with right upper quadrant abdominal tenderness, and lab findings concerning for methotrexate-induced liver inflammation. So sort of pulling all those things together. For the next one, I'm seeing them start to trickle in. And yeah, so these are all exactly right. So this is a 55-year-old male, a past medical history of hypertension and hyperlipidemia, chronic kidney disease, and atrial fibrillation. And importantly, is not on anticoagulation despite the atrial fibrillation, which is a risk factor for stroke. Presented with new onset, partial paralysis, concerning for stroke, for which he received a clot breaking medication, which is tissue plasminogen activator. So this next one, so this was one where it is a lot of read between the lines. So this is a 67-year-old male with a past medical history of coronary artery disease, for which he received percutaneous coronary intervention. So this is when they go in with a basically a long flexible tube that goes all the way up to the blood vessels in the heart and opens them up. Remains on dual antiplatelet therapy, presenting for shortness of breath on exertion and dark bowel movements with low blood counts, concerning for an upper gastrointestinal bleed. So he's received an IV medication to help treat the bleed, and is not allowed to eat, with a plan to evaluate his upper gastrointestinal system more closely with a fiber optic camera in the morning to see where the bleed is coming from. For this next one, so this is a 45-year-old female, no significant past medical history, who had a motor vehicle accident, resulting in what's called a hydropneumothorax, which is air and fluid in the lung, and then also air in the abdomen, which suggests trauma that has caused things to leak that shouldn't be leaking, for which she underwent an exploratory surgery of the chest and abdomen. Unfortunately, is recovering well on patient-controlled pain management in the intensive care unit. And then this final one is a 63-year-old male with a past medical history of chronic obstructive pulmonary disease, who's presenting with fevers, cough, and shortness of breath on exertion, concerning for pneumonia, who is now improving on intravenous ceftriaxone, which is an antibiotic. And so I recognize these are all sort of purposefully difficult ones, but I hope it gives you a sense of how much information can come from a one-liner, in terms of really you get a sense of exactly what has happened, what brought the patient in, and what has happened, and where that patient's trajectory is going, in a very short, concise statement. So it really is the power of sort of this language to allow us to communicate and take care of patients quickly and easily. But I think if there's one thing I can say, it's that you shouldn't communicate the same with everybody. So really know your audience. So I mentioned this before, you don't speak like you write. So generally, when you're speaking, you're going to want to use the full condition rather than the acronyms. There are certain abbreviations that are discouraged. So U or for units, QD for daily, and then MSO4 for morphine are three examples of things that are discouraged. And the reason is because they can be quite confusing. So they're acronyms that are consistently used for other things as well. And as a result, if you use them, your audience doesn't know what you're talking about, which you're talking about. And then again, medical lingo is great for communicating with medical professionals, for using these sort of one-liners to quickly give a sense of what's going on with the patient. But normal English is always best when talking with a patient and families. Like, you shouldn't be talking to a patient and family and talking about their transaminitis. You should be talking about the fact that their liver is inflamed. You shouldn't be talking about their cerebrovascular accident. You should be telling them that they have blood clot in their brain that's causing their brain to not work correctly. So knowing who you're talking to, and then always making sure to use sort of the simplest terms, the most approachable terms when you're communicating with patients and families is really, really important. And part of the reason for this, and I really can't emphasize this enough, is there are many barriers to appropriate medical care in this country. Access to doctors and specialists, insurance costs, having ancillary support at home. I could go on and on and on. But I would say one of the most underappreciated and arguably most important issues really is medical literacy. So this is a study that came out of iTriage several years ago that showed that the majority of patients can read, but only 12% would be considered health literacy, which they define as this ability to obtain, process, and understand health information. And then most importantly, to be able to use that information to be able to make appropriate, informed healthcare decisions. And this was a really striking and unfortunately not surprising finding, which is that 50% of patients leave their doctor's office not knowing what they were told and what they're supposed to do. And you can easily see how this would be the case, both from time limitations, as well as just like these medical conditions are quite complicated. Medications are quite complicated. Knowing what the next steps are in a medical system is quite complicated. And so I really can't emphasize enough, like, our care is worthless if the patient doesn't understand why we're doing it, how we're doing it, and what they need to do next. And so there are some simple steps to be able to take that. And one is to know your audience and sort of assess health literacy with sort of the teach back method, which is once you say for a patient to do something, for that patient to say it back to you to make sure that they truly do understand it. The other is to include multiple forms of information. So not only saying it to the patient, but writing it down for the patient, sending it to them in their electronic chart for posterity. So if like 5 days later they forgot what you said, it's there for them to look up. And then saying it to multiple people. So maybe they have a family member who is more health literate who can help them with their care. And you should really involve them in their care to make sure that the steps that need to be taken are taken. And so again, this often goes without saying, but understanding that there are risk factors that can identify poor health literacy. And again, we should really take it on ourselves to make sure that we assess health literacy and assess understanding of sort of the treatment plan that we have moving forward. And so with that, I will stop and thank you all for your attention for this very important topic. I am very much open to any questions. You can email me anytime, and I'll be available for any questions that you all might have at the end of this as well.
Thank you so much, Dr. Moore. And honestly, this is truly a topic that you bring to life. So that was fantastic. Thank you so much. Anyone, if you have any question, by all means, you can unmute yourself or put it in the chat. I know we are almost at the hour, so I want to be respectful of everyone's time.